Hey, everybody, it's Dr. Jay Harness from Breast Cancer Answers. And it's a real treat to be back with you again. And this is going to be part two of our series of food as medicine. And it's also a real treat for me to have with me again today Dr. Gordon Saxe, MD, PhD. Gordon is a dear friend and a real expert in this area. And Gordon is the executive director of the University of California at San Diego Center for Integrative Nutrition. When we did part one, it was really sort of a let's get this thing going. We had no idea what the reaction was going to be. And the reaction to part one has been outstanding. The messages that have come back to me, people are saying, we want to learn more, this is terrific, etc. As I've shared with Dr. Saxe, we've had nearly 2,500 views of that original part one, and more people are sharing this all the time. So Gordon Saxe, welcome to part two of Food as Medicine. It's really great to be with you today.
Nice to see you this morning, Jay.
Yep. Gordon, why don't we sort of quickly summarize one of the really important points that you made in part one, which is about the therapeutic order. Why don't we quickly try and explain that to people again, and then we'll move forward from there.
Sure. There's a concept in naturopathic medicine, the therapeutic order, which really is a formal statement of something that's been understood by traditional healing systems for millennia. And while I had not learned about it until recently, I had been studying those traditional systems for many years. And so when I was developing a conference on integrative oncology a few years ago, some naturopaths in attendance told me, your conference echoed the concepts of the therapeutic order. And they taught me about it. And it made so much sense. So it was just intuitive for me because of my past experience with traditional healing systems.
Oh, fantastic. And I remember you talked about the pyramid in part one. Why don't you just mention that again? And I loved your concept of nutrition as being sort of the base and the soil, if you will, of how we proceed.
So as we go from the base of the pyramid up to the apex, at the bottom are those things that we do to establish conditions for health. In the context of when somebody is basically well or at least stable medically, if it's this is a really important concept. If it's an emergency where time is of the essence and you need to have some kind of critical care, you don't waste time with worrying about food and so forth. The example I gave last week is if I'm in a car accident, I don't want somebody, however well-intended, to be talking to me as I lay there unconscious to tell me, oh, you just need to breathe. You just need to, you need to change your diet. And it's like, in the right time, in the right context, get me to the trauma center now.
Right.
So it's really important to put things in that context. So I'm only speaking about when things are medically stable, when there's a protected space to make kinds of healthy changes we're talking about.
Well, that's a perfect segue to what we want to talk about today, and that is the context.
Well, Jay, I just want to finish the thought here, okay?
Oh, I'm sorry. Go ahead.
Basically, the therapeutic order holds that the base that are the things that, when things are stable, are the things that we do to establish or reestablish conditions for health. And that's where diet and healthy lifestyle beyond diet comes in. But diet is really primary. It doesn't require expert knowledge. It's dirt cheap. It's as expensive as the food that you eat. And if you choose it wisely and you grow your own, if possible, then that's a potentially inexpensive, very inexpensive way to address disease. When that's not sufficient, we move up to the higher rungs in the pyramid, and that's where we get to more targeted, albeit natural therapeutics, allopathic medicine. And when that's not sufficient, the apex would be something like, if you're on the heart-lung machine and, the doctor has to breathe for you or beat your heart for you. So, and obviously that's much more expensive. So we start off by demedicalizing things and focusing on building conditions for health. And often that's enough to prevent or even sometimes even treat a disease.
Well stated, my friend. And in the future parts of Food as Medicine, I want you to also elaborate on, as you said, this is an inexpensive part of what we can do. And we're going to get into discussions of actual diets probably down the road, plant-based diets, et cetera, et cetera. When I interrupted you a couple minutes ago, I wanted to sort of lead into part two today, which is putting this food concept, Gordon, in context with cancer care, with prevention, and as we proceed through the process. So I'm going to put the ball back in your court and have you take off and let's put all this today in context, okay?
Sure. So when we think about sort of the continuum of care for cancer, we start off before it's even developed. And when people are basically well, or at least disease-free to the best of our knowledge, at that point, the focus needs to be for all of us on the things we can do, healthy things we can do to prevent disease from ever developing. And obviously, that's the most cost-effective way of approaching things of all. We all know that. And yet, sometimes, unless we have the gun to our head, we don't do those things. So it's not easy to motivate preventive changes, and it has to get to a more advanced point before people will take steps to help themselves. But in theory, that's the time when diet and healthy lifestyle are most effective.
And I'm sure you would agree that not only is the diet really important, but weight control, exercise, things that I talked about last time, which is heart healthy, obviously not smoking, et cetera, et cetera. Do you want to elaborate on that a little bit?
A slightly broader definition of diet might be not just the food that we eat, but all the things we bring into us. So that includes the smoke that we might, choose to, the cigarette smoke we might choose to ingest.
Yep.
It includes also, if we're surrounded by negative, hostile people, their hateful vibe is going to get into us. And that's something that also comes into us and influences our health. The ideas that we consider from other people, these things, the quality of these things can be healing and smooth, or they can be toxic and harmful. And so we want to choose wisely, choose things that we allow to come into us. Surround ourselves, if we can, with loving people, with really great vibes, with fresh air, with beautiful sights, and of course, most fundamentally, with healthy food.
Yeah, really well stated. So as you well know, some of the longest surviving living communities are in Japan. And not only is the diet really a key factor there in Japan, but they really make the point about the social interconnection of older people and means not only involved with families, but communities, et cetera, et cetera. It's exactly what you're talking about.
Dan Buettner, the author of the Blue Zones research, and I think there's a book called The Blue Zones.
Yeah, there is.
Went around the world and looked at different communities, and certainly in Okinawa in Japan, where the life expectancy is greater than almost any other place on planet Earth. In California, Loma Linda, where there's a large Seventh-day Adventist population.
Right.
Other areas of the world have these pockets where these factors are in place, and they have a profound influence on health.
So part of what you've just talked about is, I think, called primary prevention. In other words, the basics in lifestyle and what we consume, et cetera. But then there's a concept of secondary prevention, that if somebody knows for instance, I have a strong family history of prostate cancer. My dad, one of his brothers had prostate cancer, and one of their cousins. So talk about the concept, and somebody like myself, as an example, with a known risk factor for a cancer, what is secondary prevention?
So in that setting, it would be the same kinds of things that might have prevented it in the first place, but at a slightly further along the timeline, along the continuum, introducing them at that point in a targeted group where we know that there is a greater than expected risk. In that group, using the same kinds of things, maybe a little bit more intensively, possibly because there's greater motivation among people who know they have a family history, or they know that they have a precursor, precancerous lesion or something like that. In that setting, to use the same kinds of things to help arrest it or prevent its progression to the point where it then becomes a clinical problem. So kind of arresting it at a preclinical point.
And, I'm a big green tea consumer, and I've heard people talk about the benefits of green tea, and you've got a cup in your hand. I already had my green tea this morning. I'll have some more later today. As a sidebar sort of comment, why don't you just comment on things like green tea in secondary prevention? So I have my weight well under control. I'm trying to exercise for a guy in his 70s regularly. Mm-hmm. I consume green tea. I'm not fully plant-based, but all of these elements would go into what I think you're talking about, secondary prevention. True?
Oh, absolutely. Absolutely. I usually start with the diet itself, and then I think of something like, and that has to do with the pattern of the diet. But again, we'll talk about this in more detail in a subsequent discussion. But the pattern of the diet is very important, the kinds of foods we select. And then also there are certain specific foods, possibly spices and herbs, that may add to the punch. And green tea, which contains the catechin EGCG, a potent antioxidant, is one that's been investigated for protective effects not only on prostate cancer, but breast cancer and many others.
Very good.
I don't think there is a single magic bullet that explains why, say, people in Japan or Asia who drink a lot of green tea, why they have lower risks of so many cancers. But green tea is part of probably a larger gestalt of diet and lifestyle factors.
Yeah, and then the other hot subject, if you will, has always been the Mediterranean diet and the potential of lowering cardiovascular problems and things of that sort, and the benefits of olive oils. I'm sure you're going to get into that as we go down the road. Gordon, when's it appropriate to help people with diet to reduce side effects and things of that sort? And so let's sort of focus on, are there things that we can do in that arena?
Well, sure. So I want to get back to the context of cancer care, because I've spoken about primary and secondary prevention. But then the question happens, what happens after a cancer has been diagnosed?
Great.
And as you know, sometimes there isn't a clear-cut beneficial treatment. For prostate cancer, for example, a man could have a relatively low-grade cancer, a Gleason 6 or below cancer. And in that setting, there may not be any clear-cut survival advantage to having surgery or radiation, and instead we employ something called watchful waiting.
Right.
And this is something that affects many different areas of cancer care and many different types of cancer, not just prostate. So in the setting of watchful waiting, my feeling is, well, gee, why don't we enhance that with diet and nutrition? Use that as an opportunity to empower people so they're not just sitting around passively in fear waiting for the axe to fall on them. Instead, they're doing something proactive to help themselves to reduce the likelihood that the disease will progress and become a problem. And instead, they're super enhancing with diet and healthy lifestyle watchful waiting.
Well, listen, that is really relevant also in my world of breast cancer when it comes to in situ breast cancer. Mm-hmm. Huge debate in my world that we're over-treating ductal carcinoma in situ, DCIS, particularly low grade. In fact, there's a clinical trial started by some good friends at Duke University on once we do a needle core biopsy to make a diagnosis of low, even maybe intermediate grade in situ breast cancer, intervening, not surgically, but intervening with anti-hormone therapy. And it seems to me that part of an intervention like that would also include exactly what you just talked about for prostate cancer.
Absolutely. I think sometimes the kinds of things we do, whether again for breast, prostate, or other types of cancer, often we turn to, say, a pharmaceutical, quote unquote, chemopreventive agent. I believe finasteride, hormone therapy was used in prostate cancer. There are different things that have been looked at and may play a role. But my feeling is we can affect the hormonal milieu of the body and of the cancer by changing our diet through weight reduction. We know, for example, that adipose tissue, body fat, is incredibly metabolically active and is a site. It's a tertiary site for production of sex steroid hormones like estrogen and then testosterone. So why not do things to reduce that, which include diet and physical activity and all that?
Oh, beautifully stated, Gordon. I mean, as you well know, for both prostate cancer and breast cancer, being obese is a risk factor for developing those cancers. And then I get discouraged sometimes because I have a fair number of obese patients that I've taken care of over the years who I say, hey, when it comes to your survival, it's really important we get your weight under control.
Mm-hmm.
And you've just elaborated on one of the factors that's important there. Okay.
Absolutely. And I'm so as we continue on sort of with the continuum of cancer care, the next thing that we get to is the situation where a woman, or for breast cancer, a man has been told that they need to have conventional treatment, whether it's surgery, radiation therapy, chemotherapy, or possibly hormonal or immunotherapy. And in that setting, there will be some people who are compos mentis, who are competent to make a decision, and who, for whatever reasons, philosophically, it violates certain principles, will choose that even after an informed discussion, I don't want this. Now, I'm not advocating that position on the part of patients, only acknowledging that some people choose that. And I feel that often we abandon those folks. So my thought is, well, at a minimum, let's continue to offer and help support and guide them in healthy dietary and lifestyle changes, and serve as a bridge to be a conduit to help connect them with conventional treatment and answer maybe some exaggerated fears that they have, so that we can be a bridge to help them get into treatment if and when they feel ready for it.
Yep. No, well stated, Gordon. No, when I was at UCSF in the East Bay program in Oakland, I had a fair number of patients from Berkeley. And these are really, really bright people. I mean, PhD level, master level people. And I was amazed the number of people who I was taking care of with all sorts of different cancers that almost shunned conventional therapy. So your point is really well taken.
And again, I'm not advocating that, but I think it's important to acknowledge the validity of people's views, because there is, even if it's not ultimately the best decision for somebody to do that, there doesn't mean that there isn't truth in what they believe. And I think that people need to have that acknowledged if you're going to even be able to have a discussion with them about other ways. If they feel that their beliefs and their understanding has been respected, they're far more likely to then be able to take a step towards something that might be outside of their belief system, which might be the thing they need to be life-saving. But unless you have that discussion with them, unless you show real openness and validate their beliefs, you won't get there.
Yeah, people come in with all sorts of ideas once the diagnosis of cancer has been made. And a good example of this is, let's say somebody needs a mastectomy. They immediately think of grandma who had a radical mastectomy and was deformed, not realizing that in this day and age we have what are called nipple-sparing mastectomies with reconstruction. So they come in with a lot of ideas. And what you're really advocating here that I really like is our having empathy and compassion for our patients to understand where they're coming from and try and lead them in the directions they need to go.
And part of that beautifully. And one important direction that I think almost everybody ultimately needs to go is toward improving their health, their underlying health, again, through diet, lifestyle, and all that. So there's nothing lost in doing that, and everything to be gained in terms of helping bridge the communication so they can see that maybe their ideas are based on a misconception, maybe they're not, and we have to be open to that too. But at least having that opening, that dialogue is very helpful.
Yep. Well, let's continue on with the context, because I think
So the
next thing is probably preventing relapse or recurrence.
There's one very important piece in the middle, which is important to discuss, and that is, and this comes up all the time. What does a person who is going through active treatment do in terms of their diet and lifestyle? Yep. And the feeling there is that while you have to let the person kind of guide you a little bit, at the same time, in working with them, it's important for people to not get overwhelmed with the fear that if they don't change their diet now, badness will happen. I think that people have so much on their plate and so many worries and stresses, and I've learned over the years that sometimes discretion is the better part of valor, and the trick there, not always, and I want to give an exception or two, but for the most part, I try and take a step back at that point and say, let's do what we need to, healthy comfort foods, for example, to get through this difficult time. Go for a walk. But I've learned that sometimes if I start recommending the green tea or the medicinal mushrooms or whatever, things I have in my quiver of nutritional arrows or whatever, arrows in my nutritional quiver, that I will potentially invite a bad thing to happen. If a person feels crappy from chemotherapy, they feel nauseous from it, I don't want them to associate that with the healthy food and create an ongoing lifetime taste aversion. I want to keep that powder dry and recognize that the time they're having chemo is a small part of the rest of their life. And I want to be able to use that and encourage that for a lifetime. And so sometimes it makes all the sense in the world to step back and say, get through this first, and then we'll have that discussion. And trust me, that time will come. And if anything, I like to begin as standard care is beginning to end, because a person typically feels better when they no longer need to take the chemotherapy. The nausea dissipates, their energy comes back, their appetite improves. And I want to base natural therapeutics on the back of that natural improvement so that they'll start associating feeling better with the healthy diet and lifestyle, even if it's because they're no longer having to use chemo or whatever. Still, I want to take advantage of that timing-wise to create that lifetime change.
Whoa, Gordon, that is so beautifully stated, my friend. That is fantastic. And this is where your integrative center really works its way into all this. And you've obviously been dealing with this for many years. That is just beautifully stated, my friend.
These are the fine points of integrative medicine. All the points of articulation. How do you really integrate? Now, one thing that's being discovered is that there might be benefit for certain types of dietary changes or manipulations even during conventional treatment to enhance its effectiveness. Now, of course, a healthy diet and lifestyle might help maintain one's immune system so that the white blood cells don't get so low that a person is at risk of infection. But that's preventing side effects or complications of treatment. But I'm actually talking about, are there things that can be done to enhance the outcome from the treatment itself? One thing, and again, I'm not advocating this, but it definitely has been and needs to be further studied, and that is something called therapeutic fasting. And intermittent fasting is another variation on that. It's been learned by Walter Longo. I think he's at USC, University of Southern California, researcher there, that when some folks fast for maybe a day or two prior to the start of chemotherapy, they sensitize their body cells for a better response to the chemotherapy, and they protect their normal cells in the process. And that may enhance the long-term effectiveness of chemotherapy. So I think that while those things have great potential, I'm not advocating them, only suggesting that they really need to be studied carefully.
Yeah. So we're starting to get near the end of our interview. I want to, in part 3 or down the road, Gordon, I want to get back into this specific area in more detail, because the other hot subject right now in cancer is immunotherapy.
Oh, yeah. And
All
I
right.
think there's
So
great potential
obviously,
for.
having our immune system is in as good a shape as we can with immunotherapy. I want to hold that
Yeah,
discussion for a future part, but
that,
that
that would
is really becoming a hot subject,
and,
and appropriately so, in my view.
and I
Let's
think there's a lot that how diet can influence one's response to immunotherapy. But finally, one last point about the continuum of care,
right,
and
right,
you were starting to allude to this, and that is, okay, so after conventional treatment is over, how do you prevent a relapse? And you had talked about the association of obesity with a higher risk of recurrence and poorer survival. So certainly it makes all the sense in the world in that setting to do what we can to help not just address body weight itself, although that's a very important risk factor, but to do it through the context of a healthy diet, physical activity, possibly, as I mentioned before, intermittent fasting for some people, but things that will help to reduce body weight. And it's not just targeting body weight. Even for people who don't lose weight, there may be benefit in dietary changes, the introduction of antioxidants or other kinds of factors in their diet to enhance or to reduce their likelihood of a relapse. And then finally, in a woman who, say, or a patient in general, not just breast cancer, but in a patient who has, in spite of conventional treatment, still has residual disease, what do you do then?
right.
And the answer is you kind of loop back to where you were in the first place. And that is, if there is no good treatment, then essentially, at least at that point, you're hoping maybe in the future there will be. At that point, you kind of go back to that watchful waiting situation, and you work with a person to make the healthy changes then that will hopefully arrest the progression of the disease and keep them well for a long, long time.
Yeah, that's again beautifully stated. In stage 4 breast cancer, as an example, our hope is to manage it almost as a chronic disease.
Mm-hmm.
Women, as an example, with bony metastases can live years at stage 4. And so exactly what you're talking about is really relevant to patients like that. Well,
And
Gordon, let's go ahead and wrap this up because we're going to do more parts to Food is Medicine. You've really done a beautiful job of putting all the context together here, and we'll summarize that again in our next part. It's been an absolute treat to be with you again today. For our audience, in case any of you have tuned in late, this is Dr. Gordon Saxe, Executive Director of the UC San Diego Center for Integrative Nutrition. I'm Dr. Jay Harness, Medical Director and founder of Breast Cancer Answers. We're here for you, wishing you all the best, and look forward to seeing you in our next part on Food as Medicine.